here we go. I'm just going to today we're going to kind of discuss the rationale of the PEP and to get you to a point where you're starting to see how you have to go through the process of passing this examination. I was first licensed to prescribe in 2005, and for those of you who know me, you know the basic history here in Louisiana, and I was the first psychologist to write a prescription under a state law. And we've been prescribing now, I guess, 13 years. Well, no, excuse me, 8 years now. There have only been some minor incidences, no major lawsuits, no deaths that I know of, and everybody seems to have benefited by our services. The psychologists that are currently here in Louisiana, and I'm assuming this is a little bit similar to what's in New Mexico, the gravity and the severity of the pathology that you see is much greater once you start prescribing and people recognize that you prescribe. You will see more advanced cases, more recalcitrant cases, and while I'm a strong advocate of continuation of psychotherapy, you do have to really know your medicines in order to not do harm, and that's our primary goal. And that is the fundamental principle of the PEP. They want you to be safe. And it's APA's, the College of Psychology, that develops this examination, and they have the standard. The standard is essentially that you're not necessarily the best prescriber on the block, but you're not going to kill anybody. You're essentially safe. That's the difference. And people sometimes think of it as an expert exam. Well, it's not exactly modeled at that level. But I would urge you to learn a lot more beyond the level at which the exam asks you to be at. In other words, I would like you, if you're lucky enough to be in a state and if you're active enough to get one going in your state, then hopefully you'll be an effective prescriber. And that is my goal in helping you learn how to pass the PEP. So we're just going to talk about the fundamentals of the test itself, just the basic process, how they came about this particular test. Okay, so this is, here's what the opinion is of APA College. They say these measures are didactic knowledge. This measures simple didactic knowledge associated with the safe and effective practice of psychology involving prescribing of psychotropic medications or collaborating with those who prescribe such medications. Now, many of you, I suspect, if you're clinicians and you're seeing a lot of patients, you are often asked to give opinions about medications because family practice docs, as good as they are in their earnest effort to try to help a patient, sometimes needs additional service. It's not uncommon for psychologists to make recommendations, and I'm beginning to, it's odd nowadays, I get social workers talking to their patients and having them come to me with the social worker's recommendation about a medication. It's kind of funny now that's happening for me. Funny in a way that it's kind of reversed. Most of you are doing that, correct? You're advising somebody about medications. You feel a little comfortable about the antidepressants. Maybe you're a little off-put by the complicated bipolar patients or schizophrenic patients, right? That's pretty common. Everybody seems to be comfortable with the antidepressants because they seem to be a little cleaner, a little safer, that type of thing. You know, I know there's an organization that knocks the family practice docs, but I really don't, because they are, in a great sense, doing the best that they can possibly do. And when you get into this business, you're going to find the massive need. There are more patients than Carter has liver pills, okay, as we used to say in my neighborhood. You'll get more patients than you ever wanted in your life, actually, once you get into it. Who developed this is the APA College of Professional Psychology. There was an expert working group involved under the guidance of the Professional Examination Service. The members of the expert working group, I was in the original group for the purposes of making items that were associated with the neurological disorders and the neurotransmitters along those lines, neurochemistry. And I can tell you that most of the people in the room it was a diverse population. There were clearly PDP graduates. There was typically 3 of them there at a time. Everybody's familiar with the PDP graduates, right? Or you need a little history about that. The Army and Navy and the Air Force made the decision to develop a program for psychologists to be able to prescribe through the Department of Defense. Senator Inouye of Hawaii was the principal architect of that, and eventually it morphed into different types of training. Initially, the thought was going to be that the person would be volunteers, so to speak. None of these people were really hand-picked. They volunteered to go through the program, and the program lasted roughly 10 years. In that period of time, they trained roughly, I think it was 10 clinicians, or they finally got 6 of them practicing as psychologists, prescribing in the military. The first iteration, the idea was you were going to go to, it was down in Texas, I believe, but it was, what do I want to say? Oh, a physician assistant training program. You would do 6 months of that, and then you would go up to a clinic or inpatient unit psychiatric area and learn inpatient practice and seeing more diverse patients. The program got stopped immediately by the American Psychiatric Association. They put up a big fight. Then they took the students that decided to stay. They moved them up to USA's Armed Forces Medical School in Bethesda. They had to take the first 2 years of basic medicine. They were told that their grades wouldn't count, and they were told that their grades would count, that type of thing. So you're taking people that may have not had a big chemistry background and throwing them into a biochem class in the middle of medical school. But somehow they were smart enough to pass, and they got by. There were a few that struggled, but as the program developed and became, every year it would be changed a little bit. There was a huge amount of money being invested in the evaluation of the program, and then what happened is that the Office of Accounting in the U.S. government delivered a report saying that this training was unnecessary because it was too costly, and it was costing roughly $600,000 to train one person to be able to prescribe outside of medical school. And that became a rallying flag for psychiatrists who were opposing this because they could say it was too costly. But what they actually did was they took these individuals and they told them essentially that they were going to assess their rate of fees as if they were a full-time medical student in the medical school, and therefore the costs they were levied at a much higher rate. And the students were not getting that type of service as they moved along. At the end of the day, they got these 10 people, I believe it was 10 that actually completed, I'm sorry, I think I said 6. But the total cost for each person was continued to be a big issue, even though the efficacy was well established thereafter. But what they ended up doing, and it was never finished, it was never fully developed, but what they finished with was 1 year of didactic training, and then 1 year of being on the wards. I think that's exactly what it ended up being. So it became a 2-year training program. Now, none of the civilian training programs are exactly like that. The civilian training programs have varied in terms of the amount of information you're supposed to get, but the categories have remained the same. And that's not changed over time. But the program in the Army, Navy, Air Force died. So they weren't training them. Now they're beginning to train them training some of these military officers now independently. These are all psychologists. If you are a psychologist and you have the ability to prescribe, they will allow you to come into the service and prescribe. So they're recognizing it, which is an interesting issue because here we have one branch, the military of the government, that allows you to prescribe within the context of their hospitals and the service of civilians, as well as civilians mean spouses of military people, and yet Medicare system denies us from prescribing medication. Not that they deny it, they say they won't pay for it, which is interesting. That's two separate branches in the federal government, and they're at odds with each other. And there has been some movement in the Indian reservations to get people to be able to prescribe, and I think that's gone fairly well. And now we're seeing some of alliance efforts at trying to move into these other types of countries that might be willing to do this. And one of them has been in South Africa. Now they're working in New Zealand, and that looks like it's going to happen in New Zealand sometime soon. So the more people that get into this, the easier it is going to be to get the proper training, the easier it's going to be to find more robust tests, because no one knows for certain that the PEP itself really says you're as good as they say. This is a theoretical test on many levels, but it is based on experts. So the questions were brought together. They worked through it statistically to come up with what they thought was the first generation of this test. Now there's a question that follows. How do you know that it really says what it's supposed to? It's just a content validity type test. And most tests, like the EPPP that we're all familiar with, are not tested against some empirical group. It's a theoretical test. It says this is what we, the experts who do this type of activity, believe that this is the type of knowledge you need to be able to demonstrate. And it's generally been defensible. You know, essentially it works relatively well as best we can tell, and it's the best we have. The reason you can't do a reference group is because when you first go out and take the PEP and you want to be able to prescribe, you're still at a point of developing your skills. You haven't yet honed your skills and become more of an expert. Whereas psychiatry has a residency process where you're spending more time learning, more time demonstrating your skills, and then you move through this proper advancement. They have a nice sequence of advancement, and then they're all requested to go take their board. And in general, most of them pass without great difficulty, but their expert level is higher. So we use this, the test here is using the validated practice-based content outline. Psychologists, item writers were encouraged to draw upon actual treatment experience to ensure validity, fairness, relevancy, and clarity.